talk today about periprosthetic fractures, specifically around a hip replacement. This is a relatively common fracture, and in a large hospital where we work, we might see certainly at least one of these a fortnight, and certainly at least a few a month. They're a complex presentation. Many of them can, however, be treated by someone with a general interest in trauma, although they often do involve someone with a more specific interest in hip replacement surgery, and as it does sometimes require a revision component. If the component's planned to be revised, then a hip replacement surgeon should probably do it. However, if it's simply going to be more of an open reduction internal fixation of a shaft fracture or similar, then you may not necessarily need a hip replacement surgeon, and someone who's capable of plating a femur should be more than adequate to manage these. I'm going to just focus on the hip replacement as it does get a little bit nuanced depending on the joint that's involved. But for the purpose of this talk, we're going to simply focus on the hip replacement fractures. Now, the classification system that we use is called the Vancouver classification, and it's divided into A, B, and C, and each of them has a subdivision. For the A, which is generally considered the more simple fractures, that's a fracture involving either the greater trochanter or lesser trochanter, but the remainder of the shaft of the femur and the stem are intact and stable. Vancouver B can be subdivided into three main components, but it's a fracture that is often in more than one piece. It's comminuted, and it often it involves the fracture being around the stem of the implant itself, um, and certainly above the tip of the stem. And then Vancouver C, which is a fracture essentially of the shaft of the femur uh, below the tip of the implant, either in the shaft or down towards the metaphysis. This one, although it does require surgery, is often considered to be maybe a little bit more simple to address. So the Vancouver A, as you can see here, involves a fracture of the greater trochanter. This can occur at the time of the surgery or afterwards. Um, this one, the fracture looks to be a little old. Now, these fractures can be managed non-operatively, but they can also be treated surgically. And there are a variety of ways to treat it. And you can see in this example, there's been an attempt to use a plate with a claw system to try and hold that fragment down into position. I will state that this is quite a difficult fracture to get to unite because it's continually under tension. The fixation method commonly fails, and even if it does stay in place, it often doesn't necessarily unite and heal well. These patients, because they're often older and frail and well into their 80s, their demands are low, and there is grounds for managing them non-operatively. And that would mean the use of crutches and pain control until it settles down. They often cope reasonably well, although they are left with some sort of limp and a persistent need to use a walker or a walking aid of some description. The main group is the Vancouver B fractures. Now, these can be subdivided into a Vancouver B1, 2, or 3. And the first group, 1, is where the stem is stable and the bone is of good quality. And what that means is the stem is still attached to the proximal bone, or at least a main fragment of the proximal bone. So in this example, you might see that the stem doesn't have any lucent lines between the implant and the bone, and it's probably still got good adherence to that lateral component of the fragment around the stem itself. But you can see fracture line extending medially about halfway up the stem. And so there are certainly multiple components to the fracture here. If you had a CT scan available, you would be able to more clearly delineate the fracture pattern. Now, these ones can actually be treated like a fracture, and you don't necessarily have to see the implant itself. And it's possible to treat these internally with a plate, as shown here, supplemented by some cables. So that would require a lateral incision. We would open up the fracture, hold it in place with some sort of cabling or clamping system, while we then put the more definitive cables or plate in position. For these type of fractures, you will want fixation that extends from around the hip replacement itself and extends more distally to the distal shaft, if not down into the metaphysis as well. Vancouver B2 is where the stem is loose but the bone is still of good quality. So you can see in this picture on the left that the bone still has good thick cortices. However, the stem is clearly loose from the cement. This is a difficult fracture to fix because you do need to revise and replace the stem. And that can involve, there's a variety of ways of doing this, but you need a stem that extends past the fracture line into the distal femur, at least 2 diameters of the bone distal to the fragment or the fracture. And then you need to stabilize it proximally, as they've done here. They've done it with a cabling type system. You could supplement this with a plate as well if you wanted to. However, if there's adequate fixation distally, the stem fixed distally with good approximation of the fracture and cabling proximally is usually enough. The acetabular component does not necessarily have to be addressed or changed. And then the third Vancouver B, or B3, is where the stem is loose and the bone around the stem is of poor quality. This is probably what's led to the fracture in the first place. And in this case, you need to revise the stem and stabilize it with a plate. They've revised it here with a stem that goes approximately 2 cortical diameters below the main shaft fracture, and then it is stabilized more proximally with the plate, screws, and cable. This is a difficult fracture because the bone is often soft and of poor quality, and it's not uncommon to have bone fragments become more fragmented during the operation. This is certainly one that should be done by a hip replacement surgeon rather than someone who's got a more general interest in trauma. And you certainly want someone operating on it who's comfortable working with hip replacements. And finally, there's the Vancouver C, which is generally below the tip of the stem. It's essentially a shaft or metaphyseal fracture, and you can see here it's been reduced well and it's been held with some cables and then supported with a plate. You can see there that the plate has screws that are unable to traverse the bone because of the implant, and therefore they've used at least 4 short screws there that stop short of the implant, and then 3 extra cables around the proximal section of the fracture area. Distally, there will be more screws in the metaphyseal region, and that should be enough to fixate that. And again, this could be done by someone with an interest in trauma, as the implant itself doesn't necessarily have to be directly viewed. And these ones actually do quite well as well. So in principle, the fracture needs to be treated. The implant may need to be addressed depending on its stability. You need to take into account the age and frailty and the quality of the bone. You need to aim to have this patient walking post-operatively as quickly as possible. And from that point of view, the principles are exactly the same as a patient with a neck of femur fracture. They're usually and commonly quite a big operation with a high risk of bleeding and a risk of infection. And so there's always a few weeks afterwards where one would be a little bit anxious about the patient representing with an infection, which then obviously complicates the treatment of these injuries. These injuries often have other complications like loss of position, further periprosthetic fracture, and they can be extremely difficult to treat. So surgeons will often get friends and colleagues to come and help them, and they'll often get, or they might hand them on to a colleague who can look at it from a different perspective.